This
So
conference will
basically,
now be recorded.
yeah, so this is module 7, management of delivery. So like we talked about it yesterday, that this is a different module. So labor and delivery are two separate conditions, which can have many acute conditions as well as chronic complications can be there. So basically, what are they looking testing here? They are testing your practical skill, and as an ST5, you are expected to know about the both vaginal and abdominal routes of delivery, OBD indications, contraindications, complications, serious incident reporting, and then patients debriefing, and then follow-up. So all of these things are expected from you. Then you should know about limitations of knowledge on normal labor as well as on abnormal labor. So the new evidence, it provides some guidance that how we can keep the patient safe. But just like any other condition, we cannot apply these rules to the whole female population which is laboring, giving birth at that time. We try to keep them very safe and happy, and we try to make it a memorable, pleasant experience for them. So you should know about emergency cesarean sections indications, VBACs complications, and elective repeats C-section issues. So they should be well understood because you need to explain them to both the examiner and sometimes to the patients. So the communication and applied clinical knowledge. These two skills are very important to do these stations perfectly. So what you can do is that you should try to explore expectations and fears of the patients. Your language is good, but the examiners, they like to hear these words. They like to hear these specific words like, I would like to explore her expectations and fears. And then you should learn that how to negotiate with patients. That is very important. Giving information on both pros and cons of the vaginal and the cesarean delivery, that is essential. And the women, they should use information that we are providing them. So they should make their own choices rather than we should be taking dictation from us that what they can do and what they should not do. It is a matter of personal freedom and choice and what makes them more comfortable. So negotiation and compromise, they're the key skills which are being tested here. And so we need to practice agreeing a plan rather than deciding for the patient. And here again, you can be asked about arranging skill drills in your obstetric unit. Then they can give you just any bar and they will ask you, what is this thing? So start from introduction, or maybe it will be a teaching station, okay? How to interpret it, why it is important, what is its role in modern OB/GYN, like that. They will ask you questions like this. And most commonly, they are what domains they are testing: applied clinical knowledge, patient safety, and then communication with other colleagues. So then they can show you some, devices like that. Like here is this one that you're applying fetal scalp electrode. That how what is this thing? Do you identify the object? Okay, what is the purpose? How does it work? So don't forget that even if you have to cite this scalp electrode, or you want to do like intrapartum fetal blood sampling, you will need consent of the patient. Okay? You should say that at 36 during the antenatal period, and particularly at 36 weeks of gestation, you will like to talk to your patient about these things. That you should talk about the need for any and ultra additional monitoring for the mother, for the baby, and talk about the change in the mode of delivery. Like she develops some complication, maybe we will have to go for cesarean section. Counsel them about operative vaginal delivery because this OVD is almost always there in the OSCE. They like to ask about forceps more frequently, and they can also give you a person, a lady who who had some traumatic experience in the previous labor and delivery, and then um, she is seeking your advice that how she should proceed. So basically, they are testing that can you show empathy, and then can you make your patient comfortable, and can you tell her about her options, and all of these things are tested here. So things as per se, they will be very simple, but sometimes it can be difficult to interpret them. So more should not be an issue, because we are practicing with the same things again and again. So this is also, yeah. So these are some of the stations. Another thing I wanted to show you here was that usually this will be available for your review. If you want to go over this one, just try to talk about a few things that when you will say that this CTG is good or bad, like how you are interpreting, which I know that you already know, you must be having a good grasp on the subject. Just a reminder, I review. So this is one of the core clinical skills, right? And they are going to test you that how do you gain verbal or written consent for intervention or operative delivery. So you don't have to mention each and everything. Don't try to remember all the figures, right? Just tell them that the chance is less than 5%, chance of having this complication is less than 10 in 100, and chance of having this complication is a bit higher, like maybe like 30%, 30 maybe in 100 they can have this problem. 80 babies, 87 babies in 100 they can have this retinal small this cephal hematoma. 38 in 100 they can have this retinal hemorrhage like that. Okay. So talk about the main things. Don't go and address the petty things like that. Okay. So in the communication, again, they will ask you, can you prioritize, and do you understand that what are the indications, contraindications for a certain mode of delivery? And then you should be having the ability to make an appropriate management plan for delivery. Patient wanting to have this home birth, um, then tell her about the complications and the benefits. Okay, and you should understand, and you should be able to explain the role of the multidisciplinary team, including like involvement of the lab people and vascular surgeon, okay, and the critical care team. So, and the neonatal team, pediatric team on call. So, how you are going to collaborate a joint activity with them. You should be able to communicate verbally with the multidisciplinary team, including anesthetist, theater staff, neonatologists, in an efficient and timely manner. Sequence would be highly appreciated. If there is like a proper sequence, that is going to be very helpful. Then you should also be able to teach a couple of things to the juniors. This is not going to be a challenge because we are following the same template for all such cases like that. So then you should be in the info gathering, like they will show you certain CTGs. Okay, they will ask you to comment on them, and they can ask you that what is your opinion. So in the light of the thing information you have gathered from the CTG, what will be your next best action, how it will change your plan for the delivery, like that, stuff like that. So in the info gathering, you need to demonstrate the ability to interpret notes on progress of labor, pay attention to the timeline. Okay, we are like how we are keeping the patient safe, how we are taking actions. We are following a timeline. If the patient deviates from that typical pattern, that is the rule of the averages. Okay, the patient is deviating, then maybe we are heading towards any complication. What is a partogram? How to read it? How to fill it? Who is going to do this active and this? Who is going to maintain the partogram? Okay, and how do we test the findings of the VE? And in order, because all of these things, they are going to help you decide management of the delivery, and by both the second and the third stages. And then they want to see the clarity of your speech. Okay, what are you going to tell the patient? What is the content? Can you deliver crystal clear information, and can you make a neat and clean, easy to understand plan for the patient? You should be able to do that because we are doing it in the practice. Patient safety, like all other modules, that is highly valued here also. So we need to tell what are the principles of the safe surgery in cases of the OVD and how you can gain extra marks. Just say that you will, don't have to say that I will follow the WHO safety list. You can say that I will follow the list which describes like identification, roles, right person, right place. The person who is managing has the right skill, and we are doing the right procedure in the right place, backed up by all the facilities. Okay, several ways to describe it. A patient ID is very important. So in each station, if there is structured discussion, your opening sentence should be, I will confirm name and age of patient, and you can then I will introduce myself. I will confirm full name and age of the patient. That is one important patient safety measure. Then you should know that how you're going to do prioritization appropriately throughout your work, throughout your shift. Then if some medical errors occur, there is some omission or poor care, and then sometimes we have to apologize, and we don't have to blame anyone, as you know, like the good ethical principle. The person wants to talk to another doctor, they have the right to go and ask them. We have no issues, but we will never say anything against anyone. So all of these things are important. So then in the so and then since you are going to be the captain of the ship, so you will have to follow all principles of risk management, clinical governance in relation to management of delivery, and then you have to demonstrate your ability to critically appraise the management of delivery in adverse events. In the applied knowledge, what they can ask you about the management of delivery, including the preterm, management of malposition, malpresentation, multiple pregnancy, and ability to demonstrate clinical, technical, and creative skills. Then they can ask you that what will be your routes if you are what will be the steps of episiotomy. And trust me, this is a simple procedure, but during exam people forget to say many things. Okay, what are the steps of doing a classical cesarean section? Sometimes what they do is, I have seen them doing it. I was the clinical examiner in like 2018, okay, OSCE, September. So what they did, they brought a dummy with twins. This told you that the first baby has just taken birth, and then 20 minutes have passed now, and the second baby is transferred. So what will you try to do? So of course you will have to tell them that what will be, you will take consent, you will see, you will inform the senior, you will do the ultrasound, and then you will pull the leg or foot or anything, and then internal put any question, or you will do ECV, or you will rotate the baby to the tummy of the mom, and you will try to deliver as breech or as cephalic as you can. Okay. So all of these things are important like that. So sometimes they will ask you, very rarely, but they will mostly they will show you some anomaly in the fetus, some problem like there is cephalhematoma, there is caput, there is bleeding, caput succedaneum. So you will have to tell them that what is the cause and how we could have prevented it, okay? And what are the serious injuries and how we have to report them. You don't have to go over this whole stuff, but it will be available in your web page on your web page. So very rarely they can ask you about the dimensions of the pelvis, maternal pelvis, and the diameters of the fetal head. Very rarely. But if they ask you to give to like do a teaching station, then it can be it is quite possible that they can ask you about such things. Okay. So these are the common stations, and actually, if you will not be confused, you're going to do it very well. Okay, yeah, so any question, any issue?
No, I'm okay. It's fine.
That's very good. So here is your first case. We will do some cases from here, and then I will take you back to another section. Can you read it, or I think I should enlarge it a bit. Let's do this slideshow.
I can read it. It's okay.
It's okay? Okay, let me
Mm.
little bit larger. Let me choose this one because I want you to be very, very comfortable. So you will take 2 minutes and then we can talk about it. Sorry about it. I'm in the university and I don't know why every day they will bring like something to do. Very noisy at times, so I will mute myself
Okay.
so to maintain your concentration.
All right. I'm ready to start. Um,
Yes, dear. Anytime you are ready, just talk. I'm keeping your time.
so I will confirm patient's full name and age, hospital number with the midwife,
Okay.
um, and upon review, I would introduce myself and my role, explain to the patient briefly what's happening, that her baby's heart rate is down for 3 minutes, and ask her to change position if she's not changed already. So I would turn her left lateral to see if the heart rate recovers. If it's ongoing and the heart rate doesn't recover, I would proceed to examine the patient with consent
Okay.
and apply a FSC with consent to see if that helps. With the vaginal examination, I'm examining to see the presenting part as well as the station, dilatation, effacement, and also if there's any response, like a positive fetal count response to me examining the patient. I would get her abdomen and the amplitude of her frequency, intensity of contractions. I would look at the liquor color, observe to see if there's any bleeding or if there's meconium when I also examine the patient. Um, I would look at if she's not on continuous monitoring, I would ask the midwife to initiate a CTG, and we would also ensure the patient has a pulse oximeter so we can differentiate maternal from fetal pulse. Um, I would also start fluids if it's not already started to help with the with management if there's recovery of the fetal heart. If there's no recovery of the fetal heart, um, say after 4 or 5 minutes, I would pull the emergency buzzer, ask the midwife to pull the buzzer so that we get help with the theatre team and anaesthetists. Have them on standby just in case we need to go to theatre for a category 1 cesarean. Those would be the initial things I would do. I would check to see if fetal um, full blood count and group.
This conference will now be recorded.
You can start anytime you're ready.
Okay, so in assessing this patient, I would confirm the patient's full name and age, looking at her hospital number, NHS number with the patient, um, the criteria for making a diagnosis of severe sepsis. So, severe sepsis would mean that there is infection along with a with a SIRS response, systemic inflammatory response, and severe sepsis is where you have sepsis as well as organ malfunction in one or more organ. The criteria you would use would be um, mm, so you would look at I do right. So you would have hypotension or a lack of perfusion. Like in this case, the patient's blood pressure is 85 over 52, so she's hypotensive. There's also there would also be a feature of tachycardia as well as fever, and there may be um, lack of perfusion, so a low PaO2. The If you look at the complete blood count, then you might see neutropenia or elevated white cell count. Sometimes in severe sepsis, you could also have a low blood count, and yeah, you can also have a low blood count and also elevated lactate greater than 1.2. That would point towards a diagnosis of sepsis as well. Apart from that, you would have a source, you would look for a source of infection. Um, so you would need to get a precise history from the patient and try to find sources of infection, for example, urinary tract infection, or it could be based on their travel history. This patient has just delivered, so you would ask about her intrapartum care. Is she delivered in? If she developed any fever, which would point towards chorioamnionitis. You'd also ask, as in this case, she's having progressively worsening abdominal pain. So that can be an indication of the source of sepsis for this patient.
Yeah.
Yep. In terms of the intervention that
Mm-hmm.
will minimize risk of mortality or morbidity in this patient, so you would want to have early intervention. So you would um, activate the sepsis bundle according to your trust policy, and the aim in the sepsis bundle is to treat the patient in the first hour. So in terms of intervention to reduce her risk, it would take um, it would take assistance with the midwives as well as your microbiology team and an anesthetic team as well. It depends on the level of the sepsis and how she responds. But in that first hour, I would cite large bore cannula and begin fluid resuscitation.
Hmm.
So I would give colloid fluids like Hartmann's, and you also at the same time give um, send off bloods like full blood count, CRP, glucose levels, using these LFTs, and these all would give you an indication, like the full blood count, to tell you if the source of infection along with the CRP plate that would help you. You do liver function, kidney function test to see if there's any dysfunction in those organs, and also you'd want to start
So
IV antibiotics within the first hour as well. And you usually would start them on meropenem and see how the patient responds based on the, you'll do a VBG as well to get your lactate levels. And based on this, then you may need to involve the ITU team or the anesthetic team based on the, if there's any organ dysfunction from the patient. Early treatment does minimize the mortality, because the longer you wait, then you have the tissues being hyperperfused and they would be should be at risk more. Mm, what
that's
else?
great. So actually, this station is like atypical one, but they can bring, okay? Can be in the emergencies, but or like in the second in the module of this delivery, okay?
I
So
need
this
to
one is
send some
important.
guideline over to know the values.
Yeah. So we have to save this patient just for just you will say that, but at the outset it looks like this one, and how you would like to do? I will follow steps of surviving sepsis campaign, okay? And here I put this one because this is the OB case, so you are going to initiate meals, okay? Otherwise, so this is the gynae case, you will initiate this one. Just tell them about the step that you will call, inform the, just start with the resuscitation, ABC, and then see that how is the patient doing. Then we need to start the antibiotics in the first hour after the diagnosis, and talk about the things that you would like to give her now. You would like to do the control the infection. You would like to expand the fluid volume, circulating volume. Okay, and this one here is the, we didn't write that what exactly is the location of the patient. Location will be very important. So if they give you someone who is in the ER, A&E department, don't change the location from the start because you know, like shifting the patient, it takes a lot of time like
Yeah.
that. So just start managing the patient now. Okay, manage her first, and then send her to the other location like that.
Mm.
Before that, we should not, because otherwise, what will happen? The patient's time will be lost. That is one thing. Okay, so that's why we want to keep this patient inside. Wherever she is, we'll keep her there, and after once she is a bit stable, like maybe 1 or 2 hours after the study, then we can after the starting the treatment, then we can send her to the ICU, HDU, and then we can start further management like that. Okay, so just follow the points of the surviving sepsis campaign. So whenever we are dealing with such cases, you can say that this is obstetric emergency, the patient is deteriorating, this is a sepsis, and what are the signs and symptoms that there is a potential for the potential trigger is there in the form of infection, like maybe we did VE, we did episiotomy, maybe this is infected, maybe the patient has endometritis, so many things can be there. So I would like to explore that what happens. But first, you will stabilize your patient, and after that, you are going to do something for the patient like that. You will start the treatment. So once you have started the treatment, that what else you will like to do, and after that, you will like to do what investigations you will like to do. Okay, what investigations you would like to do, and then the another question will be why you would like to do, because you need to tell them that what will be the indication why we will be doing a certain investigation, because we will get this benefit from it, like that. Okay, then you need to tell them that how often we are going to monitor them, at the what frequency, for how long we are going to keep the patient inside hospital. Okay, fine. And once the patient has recovered, how you will know that patient has recovered? Because the parameters and everything, it will improve. In the, you know that in the sepsis we can do so many things, right? You should involve the ICU physician. You involve that. He should monitor the BP, the cardiac activity, the cardiac monitor, ECG, fluid expansion, vasopressors, monitor. Then how we are going to offer monitoring, like we do in the daily practice. We will repeat the test on daily basis. We will look at the urine output. We will pay attention to the conscious level of the patient and their vital signs, like the temperature is dropping or not, or it is fluctuating, like that. Okay. Once you give the initial orders, then you should be reviewing the patient's notes. That was there something that we missed? Okay. So you have investigated, you have managed, you have monitored her. After that, you need to review that can we learn something from here? Was there any defect? Was there some delay? Um, did we miss any red flags? Like the patient already had some risk factors like that. So you will like to review the charts like that. So all of these things you need to mention. And after that, we will have to have a debriefing session with the patient. And also we need to explain the situation to the family of the patient. So these are the things that we need to mention here. Any question, any issue, any comments?
I just think I need to read back the guidelines.
Don't worry, we keeping many stations for you to practice later also. Don't worry. These are just like we are just warming up. But you did very well, because I know that that was quite an atypical station. But sometimes they ask you about sepsis. I know that in the modern world, this is not an issue, but in the developing world, still we face many issues, no hygiene and everything. Okay, let's go to the next one. So you can start anytime you are ready.
Okay. So this patient is nulliparous. She's in spontaneous labor and has an epidural. After 3 hours of full dilatation, delivery is not imminent. For a nulliparous woman, you'd expect birth to take place between 3 hours of the start of the active stage. Right? Um, mm, in this, right, to discuss your assessment. So, in terms of assessing and counseling the patient,
Mhm.
then I would, with consent, examine the patient and I would assess to see if she has regular contractions, so the frequency and intensity of her contractions, as well as perform a vaginal examination to know the position of the presenting part, the station, confirm whether she's fully dilated or not, and if membranes were intact. Obviously, if her membranes are still intact, I would perform a ARM for the patient. But at this stage, I do believe the membranes wouldn't be intact. Um, so those would be assessment, and I would also assess for the fetal well-being to see if the CTQ is normal or not. Counseling the patient. So after doing the vaginal examination, based on the findings, I would counsel the patient uh, with regards to the next step. So if the delay may be because of malposition, so for example, then I would advise for a trial um, in theatre plus or minus a cesarean section. However, if there's no malposition and she already has good analgesia on board, baby is in a good position like occiput anterior, then we can offer her delivery um, with forceps in the room, right? Or an a kiwi. It depends on the station. I would counsel her about the risk involved, such as if we were to use forceps, there's small risk of um, trauma, marks to the baby face, but it's transient. Kiwi can cause a cephalohematoma, and those are the most common things. Then I'll explain that it's safer to have this type instrumental delivery at this stage rather than a cesarean section. I would also explain for mom there's risk of heavy bleeding, per trauma to the back passage, like third or fourth degree tears, and but it heals, and explain to her that she may need an episiotomy, but it would be repaired. Okay, right. Can I move on to part B?
Mhm.
Okay, so discuss the indications for undertaking the delivery right. So in terms of undertaking delivery in the operating theatre, that would be if there's malposition. For example, if there's occiput, um, if baby's occiput posterior or in a transverse position, or if I'm unsure of the position when I examine her. Also, if there's lots of caput or molding where I think it will be a difficult delivery, even though it's in an occiput anterior position and it may be likely to fail, then those would be reasons to perform the procedure in the operating theatre. The
Okay.
factor, the factors which will influence choice of instrument.
Yeah.
So this would include the the station. So yeah, the station of your presenting part of the
Mm-hmm.
voice. So if we're at a very low station, like +1, +2, we can use a kiwi. It depends on personal choice of the operator and their skill. So some people can use a kiwi at that station, but it's likely to pop off. So um, if mom is not pushing well, you would tend not to use a kiwi. But if you have good maternal effort and good operator skill, then you can go for a kiwi. If you're at mid cavity, I would say use the forceps, or sorry, at zero station, a forceps may be the better choice. Um, it, it depends on the gestational age as well of, of, of the baby. So in preterm babies, you tend not to use the kiwi vacuum because of the risk of hemorrhage, intracranial hemorrhage, or other things that may influence your instrument choice. So maternal effort.
Mm-hmm. Yeah, excellent. Yeah.
There's one more thing.
Yeah. Her previous history, skill of the operator and
Yeah,
and have are you able to give anesthesia, adequate pain relief
yeah,
or not?
yeah,
Because these are prerequisites, right?
yeah, yeah.
So, and then can you go for the emergency section? Because in case it fails, then we will have a recourse to cesarean section. That is one thing. Okay. So
Mm-hmm.
then among the relevant questions they can ask you, and the woman should also not have any contraindication, right?
Yes.
And contraindications, they can be maternal, they can be fetal, like maternal infection, or she has like borderline pelvis, or she has um, unusual fear of having this instrumental birth. She has read something. She doesn't feel comfortable. Her refusal or hesitancy, that is one thing.
Mm-hmm.
So skill of the operator, proper training, all equipment is available. We can give the epi and stuff. All of these things are important. I'm sorry about it. I don't know from where they have come because usually around library there are no sounds. But I'm sorry about today. So then, what else? Yeah, other questions they can ask you is that how many times you can try to do this OVD. How many times you can apply vacuum or faucets?
Mm. So the forceps is usually three, and if you
Hmm.
need to take a fourth pull, then you need to inform your consultant and have them assess and decide if that you should really do the fourth pull. The kiwi, the kiwi, I believe it has changed.
Hmm.
So now they've said you can do up to six. That
Yeah,
you can, if it's mid cavity, then you can use the kiwi to help with descent, and then you have three poles. I yeah, just change.
yeah. Three to bring the head down,
Yeah,
and three to pull the head out of the
yeah.
perineum. Okay, these
Hmm.
are the things that we can do that.
Yeah.
So let's say that you have completed an instrumental delivery. So what clinical governance issues are involved here?
Okay. So I would need to debrief the patient,
Mm-hmm.
mm, debrief the patient, document what has happened. If there were any complications like a third degree tear, I would need to do a DATEX.
Mm-hmm.
And I'll also need to give antibiotics to the patient.
Okay. So you did the instrumental delivery. When are you going to call this patient back for follow-up?
Follow-up. If she didn't have any complications,
Mm-hmm.
okay. So she can come back for follow-up with the consultant, like for a debriefing and both reflection about 6 to 12 weeks after.
Yeah, just like any routine case, that is one thing.
Yeah.
And you can add a couple of things here, like you would like to tell her, counsel her that the mode of delivery in this pregnancy is now in this delivery mode of delivery or OVD in this pregnancy, in this delivery is not going to have any effect on the subsequent pregnancies and deliveries. Okay, that is one thing. And mode of delivery will be dictated by the circumstances at the time of delivery. Then what else here? Yeah. And if she has any symptoms, we will counsel her about the signs and symptoms. And if she experiences any one of them, we will ask her to seek help. That is one thing. Okay. And we will get her, counsel her about physiotherapy, and we will give her a follow-up meeting, or give arrange a meeting with the physiotherapist, because maybe she will have to do some pelvic floor physiotherapy like that, okay, to decrease her symptoms and stuff like that. That's all we need to mention here and nothing else. So that is good. Okay. Rest of the things are fine. They made this guideline. There are some changes, but they are good. This one. Okay, let's go to the next one. There's usually, yeah, one session on twins always in the preterm or in the delivery or in the ANC. Yeah, you can start, please.
Okay. So in reviewing this patient, um, I'll do a detailed history with her, and this would include me asking things such as her parity. Well, no, she's nulliparous, sorry. In terms of if it was a planned or unplanned pregnancy, her blood group, her partner's blood group, um, her views on blood transfusions, and if she's had her surgical history, her general medical history before pregnancy, if she's being treated for anything at all, um, and her social history. What is her support like at home? If she smokes or uses alcohol, and any form of depression or any emotional anxiety conditions like that. I'm seeing her at 11 weeks in the antenatal clinic. So at this stage, we'll organize a dating scan if she hasn't had one as yet to date the pregnancy, as well as book. Um, I'll discuss with her screening tests, such as tests for Down syndrome and Patau's, but I'll explain to her that it may not be very accurate because she's having twins. Okay, then I would also start her on aspirin from 12 weeks, so offer aspirin, folic acid, and vitamin C. And I'll explain to her that this is a high risk pregnancy where there's risk to her as well as risk to baby. In terms of risk to her, she's at risk for developing hypertensive disease like preeclampsia or pregnancy induced hypertension. There's risk for anemia and heavy bleeding, so postpartum hemorrhage. There's increased risk of a cesarean section. In terms of the babies, I'll explain that there's risk for intrauterine growth restriction. There also would be risk for preterm delivery and twin to twin, like a small chance, but there's still um, placental malformation that can lead to things like twin transfusion syndrome. So those would be risks to the fetus. So based on that, then we would carry out another scan, I believe at 16 weeks, then a detailed anomaly scan at 20 weeks, and then from 24 weeks, growth scan with looking at volume Doppler for the babies. And this would continue every 4 weeks. If if there's any evidence of growth restriction for either baby or any concerns in terms of your Dopplers, then these would be done more frequently. So she would have care with the community midwife as well as consultant-led care. She would be assessed for her VTE risk. Now her booking BMI is 24, so it's likely she would gain weight because she's having twins. So we'll review all her risk factors at 28 weeks. And if she's hospitalized at all for her risk for VTA and need for dalteparin during her pregnancy or and after delivery as well. At each visit, I'll inform her about having her blood pressure checked as well as the urine check for protein. We would do, I would advise her to have booking bloods done. So I would request a full blood count to check her hemoglobin levels. Um, and then at 28 weeks, we also would do a repeat standard hemoglobin level, but also at 32 weeks as well, because she's likely to have early labor and need a cesarean section. So we just need to treat any form of anemia with this patient. If when she has her blood done, the hemoglobin is low, I would start her on iron supplements and explain to her how it should be taken, um, avoiding milk and with orange juice. Modifications to care. Okay. So in terms of modification to her intrapartum care, she presents at 37 weeks in spontaneous
87 weeks. And the
yeah,
first one is cephalic. Yeah.
is cephalic. So we would have discussed with the patient what her mode of delivery would be. And so in terms of mode of delivery, she can have a vaginal delivery if twin one is cephalic. And also, so we would, once the patient is happy, we would aim for a vaginal delivery in this situation. But we would need to have a multidisciplinary team. So I would need to have with me senior midwife, the coordinator. I'll also need to have uh, consultant during this delivery, and the consult mainly is for the second twin. So we need to make sure once this patient presents in labor that she has a IV cannula, she has a valid group and save as well as full blood count, and the anesthetist they are aware that she's in labor. We want to have a senior midwife with the patient during the delivery, and once she is in the second stage, she would have continuous monitoring. And once she's in the second stage, then the senior medical staff should be there. Once twin one delivers, we would quickly stabilize the second twin and also have an ultrasound scan available to scan to see the position of this baby, if baby is breech or if the baby is transverse. Sometimes the second twin would actually go into position and become cephalic, but we would need to keep scanning to make sure that baby remains in position. Then once this baby descends, because there's risk of cord prolapse, you would oh sorry, if the baby doesn't turn into position, then the consultant would attempt to do so either with ECV or with an internal podalic version, okay, um,
Okay.
for delivery of the baby.
Okay. Another question they can ask you here is that ideally, how much time interval between the delivery of the first and the second baby is accepted as normal or physiological? So 30 minutes, less than 30 minutes, right? But the
Yeah.
American College guidelines say that, but since this is the exam of the RCUG, so the RCUG says strategy that ideally should be like 30 minutes. But
Mhm.
the American College says that as long as the woman is feeling comfortable and the baby is doing well, no
Yeah.
rush.
Yeah.
We are afraid of, yeah. So what is the practice in your unit?
I think they go with the ACOG.
Hmm.
Yeah. So they wouldn't rush.
Yeah.
But yeah, once the second twin is doing well, they would just they wouldn't rush.
Yes. Yeah. And that is
Mm,
logical and very natural. No
mm.
need to give any stress to the patient or to the team. Yeah, that is the right approach.
So 30 minutes.
Yeah,
Okay.
30 minutes usually. But this is not like a deadline, you know. This is the rule, like the average period that we anticipate. But what happens that once the first baby has been delivered, there will be relative uterine inertia. So what they do is that they would like to determine the presentation of the second baby by the bedside ultrasound, portable ultrasound, and then what they do, and then they say that they guide the head of the baby towards the pelvis, then do ARM, side CTG, and if the woman is not having contractions, then you can start the syntocinon so that she will have contractions, okay, and she can push the baby like that. Okay. But depends that on the attending consultant, and the protocol is different for different areas. Just like you should mention the risk factors, anything, and then there is risk of malpresentation of the second baby. and the chance of having a cesarean section for the second baby, that is like 20%. Okay, so we already know that this is a, like it was your opening sentence, that high risk pregnancy, right?
Mm-hmm. Yeah.
So that's one of the things like that. Okay, so then we are scared of having this PPH. Okay, so mention that you will do the, with the delivery of the second baby, you are going to give delivery of the shoulder of the second baby, you are going to give them oxytocin, and then you are going to run syntocinon drip also for 4 hours. Okay, because there was massive stretch on the uterus, so there can be atony, and then the patient can have PPH. Okay,
Mm-hmm.
that is one thing. So these are the things, and then you can always gather points, get some points on these things, that you will have a meeting with the neonatologist, the patient, obstetrician, right? And the anesthetist. We will make a plan, okay? That what will happen, we can go down to the details also, that who will be present at the time of delivery, the doctors, the nurses, who will carry the first baby, who will carry the second baby, which doctor neonatologist will attend the first baby, who will attend the second baby, okay, all of these things. So, you're going to show them a picture, tell them a story like that, okay? So they like such things a lot. Okay, she has told us that because you are working down to the very tiny details, minute details, that who will carry the first baby, who will be the baby doctor with her, and what they will do, so that no chance of any mistake, anything like that.
Mm-hmm.
So just put in a couple of things like that, okay? And then the woman is also very happy to have this arrangement. So we will just finalize the plan. At how many weeks you would like to make her birth plan?
Is it at 32 weeks? 32 weeks?
Yeah, 32 weeks, because twins they can go anytime into preterm labor.
Mm-hmm.
So all of these things, and you will say that we would have told her about the plan and everything, and like 32 weeks, and if something goes, as long as the things are going well, no issue. Okay, that's all you need to tell her. And if something goes wrong, only then you will write down the incident report. So this is just you are presenting that the mode of delivery of the first baby, spontaneous labor. So if she's has no contraindications, we will go for normal delivery, and if he's happy, we are going to accomplish it. If there is any problem, then we will have to go for cesarean section or maternal request, or if there are some obstetric indications. For the second baby, depends that what is the position breech. We can take the baby out at ECV as, as breech, or we can do the ECV. If it is transverse, they like to hear from you that you would like to do internal podalic version. They like to know the how you will do. So you will hold the foot of the baby and rotate it and bring it down to the intact membranes like that. And this is one of the obstetric conditions where you can start syntocinon even when the membranes are intact. So all of these things you need to mention here, and then you should say that the first baby has been delivered. So we will cite the CTG carefully for the second baby. We will do the portable ultrasound, and we will keep the woman informed all the time. Communication will be a big thing here, okay? So that she is comfortable. No rush, as long as the CTG is fine and the woman's maternal, her emotional and physical conditions are stable, then we don't have to rush. But if there are any concerns, then we would like to expedite. But before doing anything, we would like to explain to her that what we are going to do and why we are going to do that. And then, if even if we have to do the ARM, will be done by someone senior. We will rotate the baby, guide the head towards the pelvis, fix it there, and then we can do ARM. And surprisingly, in the strategy they have written that in this scenario, we will not use the MNI hook. We will use the needle. Okay. Why needle? Because we want to have a tiny puncture, not a bigger one. Why? Because there is a risk of prolapse like that. Okay, and then we can start the syntocinon and deliver the baby. After that, look for the See that the oxytocin has been given to her, and we have oxytocin drip has been started. We will not pull the placenta. We will want it. We would want it to come out. It's on its own, and then catheterize the bladder. Look for any injuries, anything. See that she is stable and the babies are fine. And then we are going to do the routine care. Okay. And then after completing the procedure and everything, then I will write down everything in detail in her. I will do all the documentation, all of these things. Just them these things, like we said, that who will be the midwives. I will request extra midwives and extra staff from the nursery and these things, like you know that what you are dealing with and how you can make it a pleasant experience for her. Recently, in Saudi Arabia, they delivered 5 babies. I think it was like 7, 8 months ago. So what they did, people were appreciating it a lot. What they did, they brought 5 dolls. Okay. And then they tied those dolls to the tummy of the mom. So the mom lied down and they delivered one by one, and they brought five, NICU people, 5 nurses, and then extra OB staff was also there, the midwives and the people to help them. So they did fictitious this section, and then they were doing the skill drill. Who will take the first baby, the second baby? So it was more like, like you will have some convocation, someone, something like who will come now and who will come later, number two, number three, number four. So these things they are doing to maintain or improve patient safety, like that. Okay, so you can also put these things in your answer if you like. Okay, well done. Twins, yes, we need to read it because mostly twins is like a topic which they will bring in the preterm labor, teaching station, structure discussion, practical skill. So all types of stations they can make around twins, because while you know that what is the incidence of having a twin pregnancy? Like most of the babies are like singletons or the twins. The incidence of twins is low, right?
Yeah. Yeah. Mhm. Yep.
Yeah, that is the thing. Okay. Okay, let's go to the next one. Well done. And don't have to read the details. Just the main points and the PIN. More than enough.
Right. Okay. Okay. So
Gideon?
after introducing myself to this patient, I would confirm her name and age and take a history from the patient. In taking the history, um, I'll start by asking about the perception that she has about the reduced movement. When last did she feel movements? What's her normal pattern of movements? And if it was the first time this has happened. Okay, then I would look for risk factors in terms of the presentation with reduced movement. So I would look at things like BMI, because obesity is associated with reduced movement. If there is smoking, um, then, and other risk factors, substance misuse. Um, I would and look back at her handheld notes and also get a history in terms of booking, um, her blood group, her blood type, and if she's had scans done, if they were normal, and if she's had any complications in the pregnancy thus far. Things to also take into consideration with her history would be medical complications, for example, gestational diabetes or type 1, type 2 diabetes, hypertension, a history of hypertension or preeclampsia, any type of medical condition. So this would be based on the history. After getting history, then with consent, I'll examine the patient. So I'll start with a general examination of the patient um, in terms of appearance and in general inspection of the abdomen, general inspection, sorry. Then I would examine the abdomen, starting off with inspection, looking for any signs of trauma, and also take looking for signs of trauma. Need to retract a little bit. Along with the reduced movement, I'd also ask about signs of labor, like if there's any bleeding, pain, loss of liquor, or any foul discharge, vaginal discharge, urinary symptoms to rule out recent infection. In terms of examining the patient, I'll examine abdominally as well as um, it, a vaginal examination, like a speculum, will depend on what the patient uh, indicates. So if there's no signs of labor or any concerns in terms of vaginal losses, then I would wouldn't necessarily do a speculum. I would then do fetal monitoring or see if we can get a fetal heart, which is what we usually do to reassure the patient. Okay? So, if on performing the fetal assessment, then we cannot assess fetal heart, then the next thing to do is ultrasound scan. And it says ultrasound confirms death, intrauterine death. Discuss your subsequent management. So this would involve um, a team approach for this patient. So obviously, it would be a very distressful thing for the patient. So you would want to have your bereavement team as part of her management. So you'll have a dedicated midwife with her, and you'll discuss with the patient um, if you have an obvious reason for the intrauterine demise, then you can discuss, but you would explain that you may need to do other tests like an autopsy, but that would not be the major focus at this point in time. So you would want to have support for the patient. So I would ask the patient if she had anyone with her, if she wanted her partner or anyone to come in to support her and discuss the way forward. Usually, we would offer vaginal delivery and rather than go for a cesarean section. So I'll explain this to the patient and would start this as soon as possible once the patient agrees to. and is able to is able to mentally go ahead and have us do the delivery. So the management would involve knowing her blood group and rhesus status, as well as full blood count and group and save CRP. You'd want to do baseline investigations such as a high vaginal swab and urine MSU, and this would help guide you as to if infection was a cause for the fetal demise. Um, you would, once you have your baseline investigation, then you proceed with misoprostol, sorry, with mifeprostone, which can take up to 48 hours and followed by misoprostol based on the trust policy and guideline. For this patient, you would want to have senior staff, senior midwifery staff involved, and after delivery, you would assess her risk for bleeding. Sorry. If there's heavy risk for bleeding, you would want to actively manage the third stage and
Okay.
risk for VTE as well. You'll discuss after delivery, then you would ensure that you have, if needed, a Clyhour, and if she's need anti-D, then make sure that that's given. And again, once the patient feels emotionally well or able to, then you discuss post-mortem and explain to the patient that it can be a full post-mortem or partial. Then you also would discuss um, memorize a way to remember the baby. So you'll have the midwife talk to her about like doing handprints or footprints, doing a memory, like a book for the baby, naming the baby. Um, mm, Support wise, I would arrange follow up for the patient with the consultant, usually with the SANS team or the Rainbow team, and they would give support and follow up for the next pregnancy. We'd also counsel her about contraception before discharge
Mhm.
and offer
Lactation.
compassion. Mhm.
We need to suppress lactation if it is bothering her.
Yes, and offer, yes, cabergoline if she's, yeah,
Yeah.
into the breast milk suppression.
Mhm. That is great. So it is not only about the medical condition of the patient, it is about the overall care and the emotional support here. Okay, because this is a young person, young lady, 25, and it's very unfortunate to lose, to go through something at this age like that. Okay, very advanced pregnancy when she is preparing to hold the baby, and then something goes wrong like that. Okay? So people, they can have this depression, they can develop depression, and they can feel that it is their fault. So basically, we have to give them information and reassure them that in most of the cases we don't know about the cause, and this is not her fault. That is one thing. And give her the number of the helpline and the support group so that she can share her ideas, and then how tell her or refer her for like this counseling, proper counseling, debriefing, or you will be debriefing her yourself, but for the sport and for the relaxation techniques, yes, we can take professional help. That is always a good idea. And post-mortem is important, and you should add something that it will tell us that what went wrong, and it will have it will have its implications for the future pregnancy also like that. Okay, rest of the things are fine. Just give the patient info leaflet and then arrange for the follow-up appointments like that. Okay, thank you. Any question, anything?
No, no.
Okay, let's go to the next station. So you can start when you are ready.
Okay. So we have a 37-year-old with three previous cesarean sections, and she is 20
Yeah.
weeks with ultrasound showing anterior placenta on the internal os extending to the posterior wall. The risk associated with these findings, this can be uh, suggestive of uh, placenta previa, placenta accreta, um, and if these findings were confirmed to be previa or accreta, then there's risk for hemorrhage, major hemorrhage that can lead to hysterectomy. There's also risk of preterm delivery and so preterm labor or delivery, as well as fetal growth restriction if there's repeated bleeding, and then she'll be at risk for a cesarean section. Um, subsequent, the subsequent antenatal
Yeah,
care.
PNC.
So patient is at 20 weeks, so we would need to confirm the findings. We can do a scan at 32 weeks. However, because this patient has risk factors like the three previous C-section, I would do the scan before 32. I'll do a scan at 28 weeks to look at the um, to have a look again. And if you're still seeing the same anterior placenta extended into the posterior wall, then we can do another ultrasound scan at 32 weeks. If there's concern for placenta accreta, then we can do an MRI scan. subsequent planning for her delivery. So the planning for the delivery would depend on how things are clinically, generally speaking. If there is heavy bleeding, so if there is a major hemorrhage which can happen at any time, then she will need immediate delivery, and you would make the patient aware of this. So in terms of getting closer to term, so I would so in terms of delivery, we would want to deliver her if she's confirmed to have uh, accreta or placenta previa around 37 weeks. If you don't want her to go into labor, then you would advise her to have someone with her at home, have have transport available to come to hospital in the event of bleeding. And we would give steroids at around 32 weeks. If it's not warranted before, you give a dose of steroids in case she goes into preterm labor. You also want to optimize the patient's blood count, so you do repeat FBC at 28 and 32 weeks to check your blood count to make sure that the patient isn't anemic. And if she is, then you correct the anemia either with iron tablet or pharyngect, or if needed, a blood transfusion. If the patient was willing to have blood transfused, then you would plan for cesarean delivery by having blood available on site in the theater when doing her delivery. The surgery needs to be done by senior consultant as well as obstetric consultant as well as your gynecology consultant should be present, so you do an multidisciplinary approach. You'd also want your consultant anesthetist with the patient during delivery, as well as interventional radiology. So you'd want her delivered in a center where proper facilities are available, like a tertiary center, because of the risk of heavy bleeding. Also, you would want to plan delivery where you have ITU bed available because she may need ITU admission or HDU after the delivery. Right. Um,
Yeah. So actually, this station is like can be covered in three different stations. Like first one is the finding high risk pregnancy, antenatal care, then the plan, and then in the emergency also, like that. Okay. So we will follow the new guideline. Rest of the things are the same. So the time of delivery and everything, you don't have to like follow the previous guideline. 35 weeks, things are fine. Okay, give her some chance. Otherwise, just section her because anyhow she has to go for the section, but you will have to make some extra arrangements for delivering her for this cesarean section, right? So so detailed counseling of the patient and the husband is very important here. That is one thing. So document everything and see if, and explore their I will explore their concerns, their ideas, their expectations. Okay? And then the content is fine. No issue with that. Okay, well done. Anything else you would like to add here?
Pediatric team
Yeah,
you mentioned them.
they should be here. Yeah, vascular surgeon should be alerted. Okay, and then after MRI, when the radiologist has confirmed that what sort of placenta is this one, here they just told us that extending onto the posterior uterine wall, right? But we need to exclude that this is not increta or percreta, like that. Okay, it's not growing into the bladder, not growing into the large blood vessels at the back of the uterus, like that. Okay, so all of these things. So we should make a neat and clean plan. and she already has like 3 sections, so you are going to consent, and this is the fourth one, and the chance of having a theta is still like it now it will increase because this is the fourth cesarean section, so it will be like 23%, I think. So we need to exclude that, right? And what else we have to do here? So that is one thing, and then yeah, we have to consent her for the section and also for the peripartum cesarean hysterectomy also, because the chance of having a hysterectomy in these circumstances is like 27%. 27 out of 100 they can have this cesarean hysterectomy, and then we need to tell her that if she has any future fertility aspirations, she should tell us. And if she is going for the cesarean hysterectomy, then our options would change. Like maybe we would like to leave the placenta behind. So all of these things. Okay, so these are just two main questions, but there will be many sub questions also like that. Okay, so usually they are giving you the idea. Which investigation is the best? TVS. Why not MRI? MRI can be done as a second line modality. Why the TVS? Because it can also show that the placenta is passing through the myometrium, or it is growing into the other structures around uterus. It can also show how you will know that this is placenta accreta or something, loss of the transducent of the hypoechoic zone, like that. That is one thing. Similar, so the similar things, but it is more about counseling the patient and advanced planning, so that at the time of operation we will not have any surprises or any mistakes. That is one thing. Okay, so we will make a detailed plan and mention that and take double consent, and we need to involve many people in care of this patient. Anything, any question, anything you would like to share?
No, it's quite interesting.
Okay, so let's go to the next one.
Right.
can start anytime you like to start.
Okay. Right. So 25-year-old with a third degree tear discuss and justify intraoperative management. So my intraoperative management would be based on the type of tear the patient has. So it said that patient has a third degree tear. So I would want to perform the repair in the operating theatre where there's good lighting. Before we start, we will complete the WHO checklist, confirming the patient's name, age, hospital number, and the procedure which is going to be performed. And we'll do a sign out, a timeout. Yeah. We would also ensure that we have valid group and save and FEC before starting, as well as I would be aware of what the blood loss is at the time. Now, I would examine the patient again before I start, both with a vaginal examination where I would assess for any other type of laceration in the vaginal mucosa, as and looking for the apex of it, as well as performing a rectal examination to assess for buttonhole tears and also to assess if the internal anal sphincter is intact, as well as the rectal mucosa. So I would verify that it's a third degree tear. So once I have assessed this, then the patient, then I would ask for, okay, sorry. Once I have assessed this, then it depends on then I would repair the torn external anal sphincter. So if it's a full thickness, um, then it can be repaired either with overlapping or the end to
Okay.
end or the end to end method, or if it's a full partial thickness such as a 3A, then I use the end to end technique. Okay. In
Okay.
terms of suture material, I would ask the scrub nurse for PDS sutures for the external anal sphincter, so monofilament sutures such as a 3-0 PDS, or you can use a 2-0 polygalactin. All right, but they both have same outcomes. Mm, I would also ask for antibiotics to be given to the patient.
Okay.
1.2 grams of co-amoxiclav by the anesthetist. And once I have done the 3A repair, in terms of doing the repair, I would ensure that I cut my sutures very short so that they're not sticking out to cause any irritation, and perform a PR exam again at the end of the repair. Then I'll do repair of any other laceration using like 2-0 Vicryl if there was a vaginal laceration. Post-operative management. We'll sign out the patient, and then post-operative management, I would do documentation of the repair.
Mm-hmm.
Debrief the patient on her on her care. I would do duty of candor to the patient, and I will also fill out a datics form. In terms of post-operatively, I would also counsel the patient on recovery for prescribe lactulose, which she would be advised to take for at least 10 days, counsel her on her diet, keeping her stool soft, and avoiding constipation, and continue the antibiotics for 7 days. I would also book her in for follow up with the consultant at the perineal clinic, as well as pelvic floor exercises, refer her for pelvic floor exercises, and
Yeah,
advise her about signs of breakdown. Okay,
that will
then,
be good. Yeah.
right. So at her 6 week follow up, the information, discuss information you'll obtain from her history. So, in this follow up, I would ask the patient about her mode of delivery, if it, in terms of her suffering this laceration, if it's all by an instrumental delivery or vaginal delivery, if she had a long labor, um, and if she bled heavily. I'd also find out about her recovery after the repair, if she's been constipated, if she's opening her bowels, if she had any incontinence deflators or stools, and generally if she was able to have intercourse, if it was painful. Yeah,
Okay.
and discuss the prognosis of third-degree tear. What will you tell the woman about plan mode? Okay. So in terms of the prognosis for a third-degree tear, I'll explain to the patient that most women would heal well by the end of 1 year. So by the end of 12 months, very small percentage of patients would have symptoms. And the most common thing would be uh, flatal incontinence. However, the mode of delivery in the future will depend on if she has symptoms. So, if in her next pregnancy she doesn't have symptoms like flatal incontinence or fecal incontinence, then we would advise her that she can have a vaginal delivery. However, she may also suffer another third-degree tear. Um, if she does have symptoms, we'd advise against vaginal delivery and recommend cesarean section. In terms of future delivery as well, we would advise, if she is able, if she doesn't have symptoms and can have a vaginal delivery, then I would reassure her that we would take steps to help her achieve this by having a senior midwife pair with her, practicing pelvic floor exercises during pregnancy, and then intrapartum she can use a warm compress. We can help to prevent it by giving a generous episiotomy at the time of delivery. If she does need an instrumental delivery during her next um, pregnancy, then rather than use forceps, then we would offer a kiwi, because it tends to be less traumatic if she were to have a kiwi delivery. So I reassure the patient.
Yeah. So again, and another question the patient can ask you here is, they will tell you that this patient had suffered a third-degree perineal tear. Today is the second day, and she says that she has had some accidents, like she is like the or she has seen some stool, some fecal matter or material on the pad. So she will be complaining that maybe the repair has not been done appropriately, like that. Okay. So we need to tell her that the tissue will take some time in healing. So this is something normal. It can occur in the initial phase stages of healing, but and we don't have to do anything for it. So she should wait and she should continue taking the same therapies, same treatment, like you have just mentioned, and then we will review her like that. Okay, so this thing can occur, but it doesn't mean that the repair is defective. There are some gaps, something, or the sepsis has started like that, infection has occurred like that. Okay, so no such thing. So, and good documentation, and then further follow-ups. They can ask you, like they can, if they want to ask you several other questions, they can ask you that the patient has come to you after like 3 months and she is still experiencing the symptoms. So what will you like to do now? So of course you would like to do the ultrasound, you would like to do the anal manometry. Is that okay in the respective clinics? And then the further assessment will depend upon the results of these findings like that. So these are the important points in her management, continuous support and reassurance. And this type of tears, like they make up like less than 1% of the tears like that. Okay, but still they want to ask you because the problem is that anyone have experiencing this oasis, they will have a poor quality of life, and they will have so much anxiety. That's why we need to address the issue very sensitively and very seriously and backed up by the evidence-based information. These are the ultimate tasks in such stations like that. Okay, anything else? Documentation, debriefing, training of the staff, and usually you must have noticed that the such incidents they occur when the new people are given the responsibilities. Okay, so we need to tell them that they should get enough training, they should know how to do the episiotomy, how to support the perineal structures, how to support the perineum during birth, and then to the woman also, like how they should care for the perineal tears like that. Okay, all of these things should be there in the routine discussion. Anything you want to talk about today?
Not in particular.
Okay, so we are meeting on Sunday, right?
Yeah.
Same time, or you like to change the time?
No, the time is okay. 4 to 6 is okay.
Okay, that's okay. So see you then on Sunday, and we have to talk about emergencies. Okay, I will send you the updated. I think I've not shared with you the updated, this schedule with you. Okay, so I
Yeah.
will. Yeah, and then another thing for the month of April, you need to share with me that when you are available so that I will plan your further, these
Yeah.
sessions and prepare the content. And you should also know in advance that what you are expected to do on that very day. Okay, dear.
That.
Take care. See you.
All right.
Bye bye.